today's topic is the diabetic diet established and emerging trends. The learning objectives are to understand the current nutrition recommendations, to lower postprandial diabetes, how the order can by exploiting hormone release. Third, the advantages of emerging diet strategies such as eating vegetables before carbohydrates. Today's speaker is Dr. Aris at the Neely College of Internal Medicine in Cleveland Clinic in Ohio, and her fellowship in endocrinology, diabetes, and metabolism at the University of Illinois. She is an associate professor at the San Beda College of Medicine and the Ateneo School of Medicine and Public Health. She is currently the head of the Center for Weight Intervention and Nutrition Services at the St. Luke's Medical Center, Global City, the head of the Nutrition Committee of Asian Hospital and Medical Center. She is editor-in-chief of the Diabetes magazine and the past president of the American Association of Clinical Endocrinologists, Philippine chapter. May we now call on Dr. Fontanilla.
Good morning, everyone, or good afternoon, or good evening, wherever you are in the world. Thank you very much, Dr. Arcila, for the very kind introduction. So I'm very excited to talk to you about the diabetic diet. I'm sure every one of you is logged on right now is very interested because a lot of your patients are asking you about what to eat, what not to eat, what should I put on my plate. So this talk will give you some ideas. Right, so because this is CME activity, these are my disclosures. Okay, the learning objectives were already read earlier. So this is the outline of my talk. I'm going to talk to you about a little bit of an overview of what diabetes management is currently, what are the nutrition recommendations or guidelines on nutrition, what is the role of incretins in postprandial blood sugar control, and what are some of the emerging diet strategies like the eating order diet, and the second meal effect. So I'm going to present to you the current working thought about what the pathophysiology of diabetes is. You've probably heard in medical school there are three basic problems in patients with diabetes, but now there's, it seems that there are at least 11 defects in people with diabetes. So the basic ones are problems with the pancreatic insulin secretion, increased hepatic glucose production, and decreased glucose uptake. So those are the basic defects that we used to know about diabetes, and so many more things have evolved since then. And we know that there's also a decrease in incretin effect, and I will explain that in more detail later. There's increase in glucagon secretion because of these out-of-control alpha cells in our pancreas. There's increased lipolysis, so even the fat cells are involved in the pathophysiology of diabetes. There's increased glucose reabsorption in the kidneys. We have maladaptive kidneys in patients with diabetes, so they actually reabsorb more glucose. There's neurotransmitter dysfunction or central nervous system dysfunction that causes elevations in blood sugar. And now there are newer things that have come out. The abnormal gut microbiome, or the intestinal bacteria, the composition actually increases of diabetes and obesity if it's the abnormal kind, and the increased rate of glucose absorption in the intestines and stomach, as well as the immune dysregulation or increased inflammation in people with diabetes. And these days, there's just so many medications that are available to treat people with diabetes. The final common denominator of all these defects is really a defect in insulin secretion. Right? And all these medications are available. We have our old reliable sulfonylureas, we have metformin, we have our DPP-4 inhibitors, GLP-1 agonists, and all of these target different defects in the pathophysiology of diabetes. So currently, the goals for glycemic control, according to the American Association of Clinical Endocrinologists, are less than or equal to 6.5% in people who are not seriously ill, who have had diabetes for very short period of time, or low hypoglycemia risk, and slightly higher targets for those who have concurrent serious illness. A target organization less than 7% would be a goal, but for the most part, we do individualize the goals. So people who are sicker or have shorter life expectancy, older or frailer, then we would probably make their goals less tight. This is the blood sugar control algorithm from the American Association of Clinical Endocrinologists. So all patients will be treated with lifestyle therapy. Everybody should be encouraged to have a healthy weight, to watch their diet, to exercise 30 minutes a day at least. And it looks at the different HbA1cs of the person coming in and the options for therapy for each level of HbA1c. So for HbA1c less than 7.5%, you could choose to do monotherapy. For those patients at A1Cs of 7.5 and above, consider dual therapy. And for HbA1cs of above 9%, you would consider doing triple therapy, insulin, or even dual therapy. So all these medications, so many medicines available now to treat all these different defects in our patients with diabetes. But one of the targets for treatment in patients with diabetes is a post-meal hyperglycemia, or the blood is cause increased oxidation, inflammation, endothelial dysfunction, risk for macrovascular disease, strokes, heart attacks, retinopathy, cancer, cognitive impairment, increase in the carotid intermediate thickness, and decrease in myocardial blood volume or blood flow. So to help address those postprandial blood sugars, nutrition is very, very important. And throughout the decades, several changes in nutrition recommendations have come out. But consistently, I mean, nowadays, most of the guidelines will seek to individualize the diet. Right? But what's pretty consistent is limiting saturated fat, limiting free sugar intake, and reducing cholesterol intake, limiting also sodium intake, and encouraging fresh fruit and vegetables, and increase in fiber intake. So for the optimal mix of macronutrients, how much carbohydrates, protein, and fat, there's really no ideal percentage of calories from carbs, proteins, or fats for people with diabetes. These need to be individualized, and ideally you should see your dietitian to help you out with choosing the right proportions of these foods in your diet. So we talk about now eating patterns now in people with diabetes, and so many different types of eating patterns have been seem to be effective in patients with diabetes. So Mediterranean style diet, or the DASH style diet, a plant-based diet, mostly vegetables, lower fat and lower carbohydrate patterns have all been shown to help people with diabetes. And carbohydrates really are one of the main determining factors of the post-meal blood sugars. So the amount of carbohydrates in the meal and the amount of available insulin in the body. So for people with type 1 diabetes, it's very, very important, the amount of carbs and the amount of insulin they inject themselves in controlling the blood sugar. So it's very important to monitor your carbohydrate count for a lot of people, particularly those on insulin. So one way of telling people on how to control their blood sugars is to monitor their carbohydrates. And one way of doing that is looking at how much carbs they're taking. So approximately a proportion of 15 grams of carbs. Those on your screen show how much 15 grams of carbs are. So a slice of bread is equivalent to maybe a third cup of cooked rice, half cup of cooked pasta, small potatoes, a medium apple, or maybe half a medium banana. And some patients are taught how to give insulin for those particular carb choices. So usually it's like 1 unit of insulin for 15 grams of carbs. So for the most part, for carbohydrates, we would like our patients to choose the healthier types of carbohydrates, like vegetables, fruits, whole grains, legumes, and dairy products, and especially those that don't have added fats, sugar, or sodium. And one thing to look at in patients with, in foods with carbohydrates is to look at the glycemic index and the glycemic load of the foods. So there are low glycemic index foods, there are high glycemic index foods, low glycemic load foods, and low glycemic load foods. So what is the glycemic index? Basically, it tracks the carbohydrates based on their immediate blood glucose response. So it talks about the glycemic quality. How is it measured? The glycemic indexes are measured in lab. Patients they look at the increase in blood glucose above fasting over 2 hours after they ingest 50 grams of a certain reference food. It could be a slice of bread or rice. And then they look at and they rank that different foods according to that. And the glycemic load helps predict your blood sugar response to a specific amount of the specific carbohydrate. So it actually talks about both the quantity and the quality of your carbohydrate. So glycemic index of under or equal to 55 is low, and 70 and above is considered high. Anything in between is medium. So these are this is a list of different types of different glycemic indices of different foods. So as you can see, the ones in green are the low glycemic index foods. The ones in red are the high glycemic index foods, and the blue ones are in between. So examples of low glycemic index foods are brown rice, sweet potato, canned baked beans, whereas those with high glycemic index foods are glutinous rice, white bread, cornflakes, of course, glucose, watermelons. And looking at glycemic load, low glycemic load is less than 10. High glycemic load is more than 20, whereas a medium glycemic load is in between those numbers. So if you look at the different glycemic index and glycemic loads of these types of food, the best ones will be the low GI, low GL foods. And what falls under that category are the whole meal cereals, your peanuts and strawberries, whereas the ones that fall in the high glycemic load and high glycemic index foods, such as potatoes and cornflakes. I have a picture of watermelon to show me or to remind me to tell you, although watermelons have a high glycemic index, they do have a low glycemic load because the amount of carbohydrate in a slice of watermelon is actually quite little. It's mostly water and fiber. So it's low in glycemic load, even though it's high in glycemic index. So another thing to look at for carbohydrates are the fibers and whole grains, the amount of fiber in the diet. Diabetes is recommended to have at least approximately 25 grams a day of fiber. And try to limit simple sugars in the diet. So while substituting sucrose-containing foods for isocaloric amounts for other carbohydrates may have similar blood sugar effects, consumption should be minimized to avoid displacing the more nutritious or nutrient-dense food choices. And free fructose, okay, what is free fructose? Those are naturally occurring substances in your foods, like fruits. And they can also result in better glycemic control compared to the same amount of calories from sucrose or simple sugars or starch. So free fructose is not likely to have any detrimental effects on your triglycerides as long as you don't take too much. And too much is more than 12% of your energy. And people with diabetes should limit or avoid sugar-sweetened beverages, especially those that are sweetened with high fructose corn syrup, because these have been associated with higher risk for weight gain and worsening of your cardiometabolic risk profile, increasing in triglycerides, reduction in HDL, or good cholesterol. Now this is a nice picture. It shows you just how much sugar you're actually taking when you drink these drinks, right? So it's anywhere from 8 teaspoons of sugar to almost 20 teaspoons of sugar in one bottle of a soft drink. All right? So these are so available in the supermarkets or vending machines, and you wouldn't be shoving 20 teaspoons of sugar in your mouth, right? I mean, you would think of that, like most normal people wouldn't, right? But that's what you're doing every time you drink these drinks. So you just have to be aware of that. So one way of helping our patients out with their diet, this is actually very, very simple, very, very patient-friendly, is to just have a healthy plate. Okay, so for the American Diabetes Association, a healthy plate looks something like this. So half the plate should be filled with your non-starchy vegetables. So that's eggplants or leafy vegetables like lettuce or spinach. And a fourth of it, okay, is filled with your protein. A fourth is 1 serving of your carbohydrates, okay, like rice, or potatoes, or bread, or starches like root crops. And there are other things that might help lower blood sugar when you take them with your food. And definitely high fiber, low GI foods will help. Taking nuts, olive oil, and fish oil will help lower triglycerides. Putting vinegar to your salad, adding vinegar to your salads can help actually lower postprandial blood sugars. Taking more high biological value proteins, cinnamon in tea can also help lower blood sugars. Let's just show you one study where they used vinegar. They put 2 tablespoons of vinegar and put it on 2 slices of white bread. And this showed it actually slowed gastric emptying and improved satiety in the patients who had the bread with the vinegar. And these were the blood sugars. The lines in purple are the blood sugar levels of those that had bread with vinegar. And they were much lower than those that had just bread. Now we come to the, I said I was going to explain about the incretin effect. So I'm going to bring you back to physiology class. Which of the following is going to make your body release more insulin? Is it A, IV glucose, B, oral glucose, or C, I'm going to get the same insulin rise with either one? If you remember your physiology, then you would know that the answer is oral glucose will actually make you have a bigger bump in insulin rise. And this is shown in this study. Patients were given the same amount of glucose, IV and orally, right? But those that were given oral glucose had a higher bump or a higher rise in insulin compared to those that were given intravenous glucose. And that's what we call the incretin effect. And in patients with diabetes, if the one on the left is normal, patients with diabetes on the right, we have reduced incretin effect in patients with type 2 diabetes. Right? So that's why they develop these medications that will help with that incretin effect. And where did that word incretin come from? It comes from the mistaken notion that the intestines secreted insulin. And we know it's not an intestine that secretes insulin, the pancreas that secretes insulin. However, our gut or intestines do secrete a hormone that make our pancreas release more insulin. So they did develop these drugs, and one of them, the first was discovered from the saliva of a lizard, a venomous lizard. These are the GLP-1 agonists. They found that these lizards eat only like 4 times in a year. It's really substance in this lizards, and it causes an increase in your insulin rise, and therefore lowers blood sugar. So that substance is the GLP-1 or the glucagon-like peptide 1, and we have medications that mimic that. And they're injectable. We also have oral medications called the DPP-4 inhibitors, which inhibit degradation of these incretins, incretins called GLP-1 and GIP. Right. So in our bodies, we do have GLP-1, or glucagon-like peptide 1, and GIP, or glucose insulinotropic polypeptide. And these substances have, fantastic effects on the body. They increase insulin secretion, reduce glucagon. Glucagon is a hormone that makes your blood sugar go up. It helps protect the beta cells or your pancreas and slows down gastric emptying. And 80% of the effect of the incretin effect is from GLP-1. 20%, about 20% is from GIP and other incretins. Which is the background now for the eating order diet. Okay, the eating order diet is some very nice studies out of Japan that looked at this. All right, and as a background for that, they looked at these studies that have gone before, looking at how much of a particular substance like protein. Now, if you eat your protein before the meal, would that help with your blood sugars after? Or if you ate your protein with your meal, would that also help? So in this study, they looked at taking protein before a carbohydrate meal. And they fed patients beef-flavored soup. They had 3 groups. So one had the whey protein with the soup before. They had their potatoes. They had whey protein with the potatoes, which is the whey in meal, and they had those that didn't have any whey protein at all. Okay, so they looked at gastric emptying, and it was slowest in those that had whey protein before the meal. Blood sugars were also lower in those that had whey protein before the level, and they had the highest GLP-1 levels. Those patients, those subjects that took whey protein before their carbohydrate meal, they had the highest release of their GLP-1s. And how about fat? If you take fat before your carbohydrate meal, would that do anything to your blood sugar rise? So in these patients, subjects, they gave 30 milliliters of olive oil before they had their mashed potato meal. And they saw that with olive oil, there was reduction in blood sugar, there was reduction in insulin levels, lower GIP-1 levels, but higher GLP-1 or glucagon-like peptide, which is one of our incretin hormones, which could probably explain why the blood sugars were lower and because the gastric emptying was also slower. Right. So this is the eating order diet now, which the Japanese have done. So this is it's a crossover study, very small study. They had 15 patients with type 2 diabetes. So one group, they took their rice before they had their vegetables. And the other group, they took their vegetables before they had their rice. And their blood sugar and insulin levels were measured at various times after each test meal. And this is what they found. The clear circles are those that took rice before vegetables, and the black circles are those that took vegetables before the rice. And as you can see, blood sugars were actually lower in those that took their vegetables before the rice. Post-prandial blood sugars were about 20% lower, and their insulin levels as well were lower. Those patients who took their veggies before their rice. So they extended it. So they made a bigger study. It was a randomized controlled trial with over 100 patients with type 2 diabetes. They compared the veggie before carb meal, or eating vegetables before carbs, and the exchange-based meal plan, which is a standard meal plan. It's developed by dietitians. Okay. And if you look at the HbA1cs, or the blood sugars over time, those that had the veggies before rice actually had much better blood sugars compared to those that had just had exchange-based meal plans. And they found that those people with the veggies before carbs meal ate more green vegetables, had more fiber, more low GI foods, and the diet was actually more acceptable for them. And they eat less fruits though. And when they look at mean amplitude of glycemic excursions, how do you measure that? You put a continuous glucose monitor in a patient, which measures blood sugar every few minutes or so. So this was in patients with type 2 diabetes. So patients with type 2 diabetes and with normal blood sugars, they looked at their blood sugars throughout the day for 24 hours in what their blood sugars were when they took veggies before rice or when they had carbs before veggies. So the veggie before rice group were those in green, and their blood sugars were lower compared to those that had the carbs before their veggies, whether you were a normal person or you had type 2 diabetes. So this is what the patient education brochure looks like in Japan. In those patients, they taught veggies before carbs. So they ate their veggies beforehand. That could be their seaweeds, their mushrooms, their salads. Their main dish would be the meat, the fish, the soybeans, and last would be their rice, their potatoes, their pumpkins, and the corn. And patients are instructed to 20 before they diet. So the effect of eating veggies before carbs on long-term blood sugar control is pretty good. HbA1cs are better after 2.5 years in this retrospective study, and HDL levels, or good cholesterol levels, are also better in the veggie before carb group versus the control. So there are some advantages of eating your veggies before your carbs. It's pretty simple and easy to teach patients. It facilitates appropriate behavior changes to increasing consumption of vegetables, reducing rice and sweets, and it's advisable for both people with diabetes and those who are pretty healthy, who don't have diabetes. And lastly, I'll talk to you about the second meal effect. In this second meal effect or second meal phenomenon, previous meal apparently is able to modulate the blood sugars after another meal. So let's say having something before breakfast, more protein or more higher protein or lower GI breakfast may actually help lower blood sugars after lunch. And these are the studies that show that. And what is the basis for this? Maybe because the ingestible carbs or the fiber boosts quadratic fermentation, which can improve insulin sensitivity. And eating lactic acid or sourdough bread can also improve that. Glycogen and insulin levels, when you eat versus skipping breakfast, you suppress your free fatty acid production. There's higher insulin release, improved insulin action, skeletal muscle glucose uptake, and glycogen storage. And other explanations are there's also an increase in your adiponectin, which is a good hormone level. It reduces your enzyme. So this is one study that shows a patient that eats low GI meal, okay, and then they looked at their blood sugars after having a low GI meal. So a low GI meal are those in the blue squares, and those that had a standard meal in triangles. So those that had a low GI meal for the first meal had lower blood sugars after that, but that extended also to their second meal. They had, even though they ate the same exact thing as the control group, they still had lower blood sugars if they had a lower GI meal on the previously. How about having more protein for breakfast? Okay, so they compared a high protein breakfast versus high carb breakfast. Right. And patients took in the same thing at lunch. So those that had a higher protein breakfast had lower blood sugars both after breakfast and after lunch, even though they ate the same exact thing for lunch as the control group. It seems that this is probably explained by the increase in your GIP levels. So in summary, postprandial hyperglycemia can raise your risk of morbidity and mortality. Nutrition therapy for blood sugar control must be individualized, and you have to consider the amount and type of carbohydrate in each meal plan. And modulation of your incretin hormones can probably explain the blood sugar lowering with certain types of food and certain orders of eating of your food. And eating veggies before your carbs is a patient-friendly meal plan that can be effective in improving several dysmetabolic parameters. Thank you very much for your attention.
Okay, thank you for that insightful lecture, Dr. Wanda India. We would also like to thank today's sponsors, MSD and Nestle, and our media partners, the Philippine Daily Inquirer and the Filipino Doctor. Let us now proceed to our question and answer portion. Um, okay, first question now is from Dr.
Okay, so Glucerna or other meal replacement products, there's a lot of products out there that we consider diabetes-specific formulas. So a lot of companies have different types of those. So in general, these diabetes-specific formulas are lower in glycemic index, lower in glycemic load compared to the standard formulas, which are not diabetes-specific. So these formulas compared to the standard ones don't increase your blood sugar as much as the standard formulas. These can be used two ways for people with diabetes. For those who want to lose weight, you can use them as meal replacements. Right? So they can use to substitute for their lunch or their dinner or a snack instead of their standard whatever lunch. So for example, if they eat normally a 1,000 calorie lunch in McDonald's or some fast food joint, and then instead they have these, it's all because you already know how many calories one serving of Glucerna or Nutrien Diabetes or whatever. It's about 240 calories for one serving. You actually slash a whole lot of calories already that way. You want to lose weight with these products. Another way you can use them is for those patients who are not eating very well. Okay? So they're not eating so well. These can be used as supplements. So if they don't have adequate nutrition, these are pretty good. They already have carbohydrates, proteins, and fats. They already have vitamins and minerals. So they can be used as supplement for those people who are not able to eat.
Another question is about potato. So could you comment whether potato is actually a good thing to eat or not?
Okay, so we showed that potatoes are sort of in the high glycemic index, high glycemic load types of food. All right. So really, when we do a meal plan for people with diabetes, you do have your kind of your carbohydrate. When the dietitians make your diet plan, you have like a certain amount of carbohydrates for each, kind of an allowance for each meal that you're ideally supposed to take in. Right. So in general, we would prefer those carbohydrates that are higher in fiber, so lower in glycemic load or lower in glycemic index. So rather than having cakes and desserts and sugary drinks, we'd rather have the whole grains, the legumes, the brown rice instead of white rice, high fiber breads instead of white breads.
Thank you. Our next question is from Loretta Gaico. You mentioned earlier about vinegar. Were you pertaining to the apple cider vinegar or any type of vinegar such as the white vinegar?
So in that particular study I showed, they actually used white vinegar for that study. But really, it's the acetic acid in the vinegar. So any vinegar is okay. So apple cider vinegar, balsamic vinegar, white vinegar. It's really the acetic acid in the vinegar that slows down the gastric emptying. It helps with the enzymes that lower the blood sugars. So it's any vinegar is a lot of debates out there whether apple cider is better than balsamic, etc. But pretty much all these vinegars with acetic acid. It's the acetic acid that's the main ingredient that will help with the prescribing blood sugars. Okay, certain cases yes, often yes, especially in patients with gestational diabetes. Patients with gestational diabetes have profound increases in their blood sugars after meals. So in patients with GDM, we tell them instead of eating 3 big meals, they eat 3 smaller meals and then 3 snacks. So they eat like 6 or 7 times a day instead, because their blood sugar rise after a high carb diet will shoot up. So instead of them eating their carbs all at once, they spread them out.
What about red or brown rice? Are those superior than the regular white rice?
Oh yeah. So these red or brown rice that has a lot more fiber in it, because white rice is already very, processed, and the fibers taken out a lot of vitamins. So yes, those unprocessed rice with still with a little bit of the husk in it, higher.
I have a question. You mentioned something about a healthy plate, having 50% of your plate containing non-starchy vegetables, 25% protein, and 25% carbohydrates. I guess people would like to know, could you give an example of what is a healthy plate? What a sample of a healthy plate?
Okay, yeah, so we showed in the picture kanina. All right, so it could be like half your plate. You could put salad there. It's all full of spinach and lettuce with balsamic vinaigrette dressing. And then on a fourth of it, you put your fish dish, or salmon, tuna, okay, or and then on 1/4 of it, you have your 1 serving of rice. Particularly brown rice.
Okay, I guess there are no more questions. Thank you very much for that very engaging discussion, Joy. To summarize, you already helped us understand the current nutrition recommendations to lower postprandial glucose for people with diabetes. You also help us comprehend how the order by which foods are eaten can influence blood sugar levels, particularly by exploiting modulation of incretin hormone release. And you also describe the advantages of emerging diet strategies. Okay, and now I would like to just emphasize that we had 71 attendees logged in for this session, and we had 32 through live streaming. Okay, after this session, an email containing a survey link will be sent to you all. After answering the survey, your certificates will be emailed back to you. Please answer the survey so we can assess our webinar and address more of your preferences and give you materials from this session. We also would like to thank our sponsors, MSD and Nestle, and the Philippine Daily Inquirer, and the Filipino Doctor for their support as our media partners. Please invite your colleagues to join this continuing monthly CNB webinar series. All webinar schedules and resources will be posted at the following links seen at your screen. You may also email us at upmedwebinars2016@gmail.com for any inquiries. On behalf of our UPCN Class 91 and the UP Medical Alumni Society, we also thank our collaborator units, UP Manila Information Management Service, the National Telehealth Center, the UP College of Medicine, Postgraduate Institute of Medicine, and Medical Informatics Unit, DOST ASTI, and Ms. Charisse Orhado of UP Telehealth, our host. This is Lindsay now, together with Dr. Joy Fantanilla, Charissa Tabora, and the UP Med webinar team closing this session. We hope you have learned a lot from today's webinar. Thank you. We did